So, with your kind permission, shall I initiate with the introduction, ma'am?
Yeah.
Thank you. Hello, good evening, you all. Myself, Dr. Himanshu Sharma. On the behalf of Team Physio Inculcator, I am pleased to welcome you all in our today's session. Today, we have a great researcher, a great resource person, a great teacher, and a great physical therapist with us. We are privileged to have Professor Dr. Madhavi ma'am with us to share their expertise on the topic, and we are much grateful and obliged for the ma'am that they are sparing their precious time to share their incredible knowledge with us. So I would like to welcome you ma'am on the board to share your uh, knowledge. So, being a moderator, as the name is itself enough, Dr. K. Madhavi is a well-known personality, a well-known researcher and a clinician, as well as a very senior academician in the field of physical therapy. But still, as being a moderator, it is my responsibility to introduce you. Dr. Madhavi has done their graduation from the Government Institute at Chennai, and she has done their PG in the cardiothoracic physical therapy, and ma'am has done their doctorate in cardiothoracic physical therapy from Sri Venkateswar Institute of Medical Sciences University, and ma'am is having around more than 37 years of experience. Ma'am is currently working as a principal at Sri Venkateswar Institute of Medical Sciences, College of Physical Therapy, Tirupati, Andhra Pradesh. Ma'am has uh, headed clinical physical therapy department of 1,000-bedded super specialty hospital with all multi super specialty settings. Ma'am has also contributed a lot in the field of cardiotherapy, cardiothoracic physical therapy and researches. She is a member of inspection committee for granting affiliation to the physiotherapy education at NTRUHS for the Andhra Pradesh government State University since 1999. Ma'am is also a national head of Grievance Redressal Committee for the South Head Division. Ma'am has also been invited for the numerous national as well as international conferences as a chairperson, as a chief guest, and as a renowned resource person. Ma'am has also been conducted numerous workshops and CMEs on the physiotherapy, on the advanced studies at university as well as international level. And she is also extending her role in the CBR services and health services carried by the SVIMS University, Andhra Pradesh. She has been established various subclinical departments in physiotherapy like adult physical therapy, pediatric, neurology, cardiothoracic, women's health, sports, geriatric and community physical therapy. Ma'am had contributed around more than 60 research paper in the various journals of international repute, and she has delivered around more than 100 lectures in the various CMEs and workshops. So we are really much obliged and privileged to have Professor K. Madhavi ma'am with us on the board, and this is a matter of profound honor for us to have ma'am with us on the board. So again, I would like to welcome you, ma'am. A warm welcome, heartiest welcome to you on the board to share your expertise on the topic exercise prescription for the prevention and the treatment of cardiorespiratory diseases. Welcome you, ma'am. Over to you, ma'am.
Thank you, Himanshi, for your kind words. And I would like to express my gratitude to Dr. Harsh, who has invited me, and Physio Inculcators, and all IAP leaders, and my head, Humasan Gupta, who is here. I convey my greetings to Madam also, and who has given a very good platform for me in the IAP. Thank you, Himanshi. Shall I start? Shall I start?
Yes, ma'am. Yes, ma'am. Please.
Yeah. Very good evening to all of you. I've been in physiotherapy field for 27 years. So when there is an um, opportunity given for me to talk, I thought let me speak something about my specialty, the cardiorespiratory diseases, because I see at least 10 to 20 cases every day of cardiac and respiratory conditions in our institute, which includes pre and post coronary artery diseases, that is with CABG, pre and post valve replacements, and pre and post lung conditions. We have been seeing so many cases of cardiorespiratory, and when we speak about how to treat a cardiorespiratory, they say in an interview when I attended, how about how to teach an exercise, you ask the patient to go in and around the bed. That was the answer given by one of the person who came to the interview. And the breathing exercise. When you talk with a layman about cardiac and respiratory condition, they simply, when we give a chest physio for them, they say, why don't you clap on the back? I feel very comfortable. That is what the patients say. But basically, they don't know what is the mechanism which is going on. Even our students doesn't show much interest in cardiorespiratory. They think it is simply a breathing exercises and chest physio. So what else to do in cardiorespiratory? It is considered as a specialty which is not of much importance. But I felt and I feel that it has got lot of to be done. Even now in pandemic, it is the respiratory condition which is making the public to be more alert, and we are concentrating on the respiratory system problems for us. Unless you keep your respiratory system hygiene, you are not able to overcome the situations in the pandemic. So that is where is the cardiorespiratory, which is a vital part in our body. So base of human mobility is exercise. Lord Venkatesha, I think most of you know Lord Balaji from Tirumala, which is the hills. This is the Lord Balaji's temple and the Tirumala, a view. So I start with my session with the blessings from Lord Venkatesha. This is my institute, which is 1,000-bedded hospital, includes all specialities as well as super specialty and broad specialty, with more than 105 courses running in the institute. And we have an first, second women's medical college also. And this is my college, the front view, where we have the base run with clinicals, and first and second floor is academics. So let us see what all the topics which I would like to go through today. We'll see what is meant by prescription of exercise, what are the basic principles, what is the art of exercise prescription, what are the components of it, and how you get benefited from it, how you give a general exercise program supervision, what do you mean by behavioral techniques, how to increase adherence of exercise, what are for cardiac conditions, what is our experience in SWIMS, and what all the exercise prescription. As we all know, prescription of an exercise. See, most of us like to practice exercise prescription. When you go to a doctor, doctor prescribes a medicine in his letterhead and gives the patient what is the dosages how long it has to be taken. Give exercises, but very few of them put it in a paper, the assessment, the exercise plan, or what is the action plan for the patient. Very few of us had to practice this exercise prescription. This needs to be practiced. Unless we practice this exercise prescription, our profession needs recognition. Recognition comes only with this scientific way of adapting. Need to adapt that are designed for a specified purpose. Main goal is to integrate the exercise principles and behavioral techniques. What is the exercise principles in general? It is called as a set principle. You have to be very specific what type of exercise to which group of muscles should be given. You should know how to adapt it and with an induced mechanism. Either overload it or you start very gradually and overload it. Progress it accordingly to the patient's requirement. That is called as principles of exercise. So we should keep this in mind. When you're going to give an exercise, you should know which group of muscles which you want to give, what type of exercise you want to give, how you should start your exercise, that is intensity of exercise, how you should progress slowly. It doesn't mean that all the patients respond in the same way. So you try to change according to the patient's response and progress. These basic principles should be remembered by each and individual before you prescribe an exercise. This basic principles has to be kept in mind. Some basic principles. You should always see what is the health status of an individual. Try to go through the medical history of an individual. What was the past history? What is the present history? What was the medications he had undergone or what all the treatments he has undergone? And what was his prognosis? And why he has come, or what is the present status? What is the reasons for present status? Whether he has deteriorated or improved from the past. All this should be kept in your mind before you prescribe an exercise. Try to go through the risk factor profile. What are the risk factors an individual has? Basically, the comorbidities, diabetes, hypertension, and heart diseases and lung diseases. Apart from that, we have to see whether he has got any thyroid problems or he has got any systemic diseases or any other problems which is going to have the interference with our directly or indirectly with our exercises. That has to be noted. Behavioral characteristics. This is very important. Some of them feel very comfortable with mobility. Most of them feel discomfort with mobility. And in average, more preference is given only for the therapeutic modalities. It all depends. Some of them feel medical treatment is better than the physiotherapy. So you try to interact with the patient, try to understand what is the view of the patient, how he would like to react with our treatment. So the moment a patient enters into your department within a prescription of physiotherapy, from a medical person or he comes individually, you try to sit, try to interact with the patient, and when you're interacting, you try to know all the above factors, that is health status, risk factors. So when you're talking with the person, definitely you'll be able to understand his response or behavioral characteristics and try to understand why he has come to physiotherapy. Is just because he has been referred from others, or really he is very discomfort and he wants to get relief, or he wants to get relief and improve his fitness, or his preference is mostly on the physical treatment rather than the medical treatment. All this we should try to understand such that we can give best out of what is our plan. So before you prescribe, see, most of the time I see in our clinicals, as soon as the patient enters, the students will be allotted the both PGs and UGs according to their eligibility to treat the patient. And most of us, they say, when a patient complains of knee joint pain, and immediately the student takes him to the short wave diathermy or IFT or in a wax bath and put him in some therapeutic modality. And then he starts giving some exercises, whatever it is, or back pain starts meeting. The interaction with patient, we find very least interaction with the patient nowadays. The interaction is very important before you start the treatment. So that is what I want all of our peer professionals to understand. The treatment is a part of it, but before the treatment, the interaction with the patient is very important before you prescribe the exercise. So the art of exercise prescription. So how you prescribe the exercise is very important. This depends upon how you integrate exercise science with behavioral techniques, which leads to long-term compliance and achievement of goals. Yes, this can be achieved only if you have an interaction, try to understand the patient, and after knowing the patient's psychological status as well as his physical status, we should plan in such a way. You should also understand what is the mechanics behind. See, a patient complains with a neck pain. It doesn't mean all the patients with neck pain has the same mechanics involved. Each and every individual varies. The cause or etiology of the neck pain or a back pain or a knee joint pain or a foot pain varies from person to person. So try to understand what is the reason why he has landed up with the pain, and what is the with a combination of and cardiorespiratory endurance with inclusion of optional recreation games and a cool down which you want to get. based on that, you take your outcome measures. Per week you need to give. What should be the intensity of the exercise? And what is the duration of the exercises and what type of activities? So when I want to concentrate on flexibility exercise, we always concentrate on the tightness of the group, this flexibility. You want to stretch all the group of muscles which go for tightness, which is done when you stretch in a muscle. We always maintain this stretch for 15 to 30 seconds. And 2 to 4 times when you do at a stretch. Or stop with 2 to 3 repetitions before volitional fatigue occurs. So this resistance exercise is done 2 to 3 days per week. Then is the cardiorespiratory exercises or endurance. This is done for large muscle groups. It is a dynamic activity. When you do in a cardiorespiratory, you will have more of intensities which has to be increased, so that you put in a workload to the cardiorespiratory system, so that endurance improves. It is done 20 to 60 minutes, 40 or 50%, and it is done within a target heart rate. Target heart rate is one which needs to be calculated when you do in a cardiorespiratory endurance. As per the Caravanon's formula, you can calculate the target heart rate, which the formula is target heart rate is equal to respiratory heart rate plus 40% of the maximum heart rate minus respiratory heart rate. As we all know, maximum heart rate is calculated as 220 minus age. So when you calculate with target heart rate, we'll always start with intensity 40 or 30%, and gradually it is increased. So for all patients, we start with 30 to 40% of intensity. That is called as a low level exercise intensity. When you go to submaximal, you go for 50 to 60%. When you go for maximal, that is for sports people, we go above 60 or 70%. That is the cardiorespiratory endurance, how we start improving it. It is done 3 to 5 days in a week. So how this supervision, and is it really required? Because most of them, they say that you please prescribe an exercise, we'll be able to do it in the house. Yes, you can do the exercise prescription, but you should know when you can prescribe the exercise without any supervision or any supervision is required. So if the patient doesn't have any comorbidities and it is of low risk and functional capacity can be done more than 7 minutes, then you can unsupervised, you can ask the patient to do. You teach the exercise, you ask them to monitor the patient by phone, and you can prescribe the exercise. When you have comorbidities for the patient, either diabetes or a hypertension or in a cardiac risk factors or in a lung factors or in a vascular diseases, you need a professional supervision. And clinically supervised in when a patient or in a patients try to with different examples and very slowly try to importance of exercise and start involving them into the exercise in such a way you do along with them. Especially it happens in obesity patients. Mostly obesity patients doesn't get adhered to the exercise. Pathologists do it, then you should for them to do physical discomfort. This is what as less patient attended because it's not in a one-day program which we are going to give an exercise for a patient. It is weeks and months a patient has to undergo to have a physical and physiological changes in our body. Normally also the pathological changes, anything occurs, it takes more than 3 weeks. So after 3 weeks to 3 months, the repairing process and recovery process occurs. Along with that, we need to correlate or collide our physiotherapy to make some changes. So this change which has to be brought is a lot of involvement is required from both physiotherapist as well as from the patient to get a physical as well as physiological changes. This physical and physiological changes has to be noted and it has to be explained and appreciated by this patient such that he can involve himself in the exercise. So how an exercise adherence can us when we want to go for a walking or get up early in the morning and do some exercise, we show more interest to have coffee or tea. Get up early in the morning rather than moving our body. Most of us, some mobility or some movement when we have some facilities or changing facilities. That is, when our surroundings should have such an environment, we are able to do some exercise. Some motive to do exercise. Always motivation occurs with our friends or colleagues or with family. So we should see how we get motivated. Do in a short-term and realistic goals. See, suppose I am 62 kgs weight. I should not have a goal to go for 54 kgs. I should have a goal to reduce 1 kg for 2 weeks. That will be an ideal rather than going off for a very long goals, which is quite difficult to achieve. And moreover, when we get motivated, what we do is we try to do a massive exercise in a day. Suppose today I'll start doing exercise because I'm very active. I do it for at a stretch 45 minutes. And that leads to the soreness. And after that, I don't do exercise for 1 week or 10 days. So you should know how to start an exercise so that it can be continued for a long period. Definitely the group participation will have more active involvement. Emphasize variety and enjoyment. So every day doing the same exercise will not help the patient. Have some music system, have some encouragement, and start doing it within a different types of groups every day so that it encourages them. Periodically check your fitness testing, which is also becomes a motive factor for you. Recruit the support of program among family and friends. Include an optional recreational game which you are interested. Establish regularization of exercise sessions and recognize participate accomplishment through system of rewards. So this when it happens, if it is in a school, unless you have a one period for sports, the students doesn't play, and unless it is made compulsory. In the same way, when you have an office also, you should make the head has to make compulsory 1 hour for an fitness. Unless it is made compulsory, the person doesn't do. It is the same with the family. The family head should say, unless you do half an hour exercise, we will not proceed with the other things. So there will not, if you put or the starting of exercise adherence should be done within a compulsion, and that compulsion has to be accompanied within a group and different type of entertaining programs so that you get adhered to the exercises. So this exercise program for myocardial infarction, CAPG, coronary artery bypass grafting individuals, percutaneous transluminal coronary angioplasty. These are the common angioplasties now done. Very few go for CAPG. When it is going to be only triple vessel disease, the option is CAPG. But at now, most 90% of the coronary artery diseases undergo PTCA because the angioplasty is advanced and you have got very simple techniques to do percutaneous transluminal coronary angioplasty. The valvular surgeries, that is mitral valve replacements, is very common because of rheumatic heart diseases, the hypertension patients, the heart failure patients, and cardiac transplant. So whatever the type of surgeries or the conditions you take, you have to consider this type of exercise, but you have to modulate according to the requirement of the patient. So what all the above cases, you also do in a flexibility exercise for upper and lower body of RMO and see that you don't increase the risk of injury. Static stretches are done for 10 seconds initially, then improve to 30 seconds according to the requirement. And you see that it has to be continued for 4 to 6 months at least. Strength training is circuit training is given. There is an increased ability to perform leisure and occupational activities and ADL and increase the muscular strength and endurance. You start with 40% of maximum voluntary contractions. Do it 2 to 3 days in a week, 1 to 3 sets of 10 to 15 repetitions, 8 to 10 different exercises, and resistance is done very gradually. Aerobic exercises, which involves large muscle activities. You can go for arm or leg ergometrics. Your ultimate aim is to increase the aerobic capacity, decrease the blood pressure and heart rate response to submaximal exercise, decrease the submaximal myocardial VO2 demand, and decrease coronary artery disease risk factors and increase ADL. So when you're doing such exercise, you see that repetition rate of perceived exertion doesn't exceed 11 to 50. 40 to 80% of VO2 max or heart rate reserve, it is there, and you have to keep the target to such a level. It is done 3 days in a week or more than 3 days according to the requirement. Start with 20 minutes, gradually progress to 40 minutes, and always you do with warm up and cool down with 5 to 10 minutes. So as I was giving you the star mark here, it is referred to the cases of myocardial infarction, surgeries, hypertension, and heart failure. So when you do that myocardial infarction, high intensity exercise may precipitate cardiovascular complications in post-MI patients. So we have to be very cautious. See to that you don't impose any high intensity exercise for post-MI patients. You have to start only with low level exercises and gradually increase according to the capacity of an individual and response of an individual. For an post CABG and valvular replacements, upper limits of early exercise prescription, that is in patients for CABG or post-operative cardiac conditions, the rate of perceived exertion should not cross 11 to 13. When you go for stenosis or pulmonary stenosis, avoid, that is valvular conditions. Avoid strength training with significant aortic and pulmonary stenosis or valvular conditions. As you know, when you start doing some resisted exercises or strengthening exercises, all of a sudden to the valve conditions, because of the placement of prosthetic valves, there is a coagulation formation and you can have an clot formation. So don't start sudden increase of strength training or any resistance training for valve replacements. You have to start very slow. Severe deconditioning is very common in the congenital heart diseases. Intermittent exercise is prescribed until heart failures also. Intermittent exercise is prescribed until continuous exercise is tolerated. So you should give very slowly and in a circuit fashion such that the patient, that is the cardiovascular system, is able to take up the load which we are giving to the patient. Where hypertension, do not exercise if resting SBP is more than 200 or diastolic BP is more than 100 ml of mercury. Hypertension, physical exercise definitely has a positive effect of BP in both normotensive and hypertensive. But reduction in diastolic BP were observed after endurance, dynamic resistance, and isometric resistance and combined training. But you have to remember, whatever the type of exercise you are going to do, you do it very slowly and progressively. Acute effects of physical activity induces a decrease in BP, typically lasts for 4 to 10 hours. The average decrease was 15 mm of mercury and 4 mm of mercury for systolic and diastolic BP, respectively. This means that people with hypertension can achieve normotensive values many hours of the day, which should be seen as having a considerable. What is the mechanism, how it gets reduced? Neurohormonal, vascular, and structural adaptation occurs. The anti-hypersensitive effect includes decreased sympathetically induced vasoconstriction in a fit condition and decrease in catecholamine levels. Hypertension often occurs in conjunction with insulin resistance and hyperinsulinemia. Physical training increases insulin sensitivity in the trained muscles and thus reduces hyperinsulinemia. Increased post-receptor insulin signaling, increased glucose transporter, mRNA and protein increased glycogen synthase activity, and hexokinase, low release and increased clearance of free to the muscles due to larger muscle capillary network and blood flow. Diseases, it cardiac rehabilitation definitely reduces hospital admissions, but not total MI or revascularization. Physical training of patients with CHD was found to reduce total cholesterol and how it reduces myocardial oxygen demand at certain exercise level. And definitely it has a beneficial effect on autonomic and coronary endothelial function, improves the cardiovascular blood pressure, HDL and LDL ratio, weight, glycemic control, and psychological well-being. So let me go to real-time data and exercise protocols which we follow in our institute. This is my PhD which I have done in a congenital acyanotic congenital heart diseases, as well as I have seen most of the coronary bypass grafts and valvular conditions. We'll see that there is 2 supervised exercise sessions per week, warm up of approximately 15 minutes including stretching, 10 to 30 minutes aerobic exercise at 40 to 60% of heart rate reserve, progressing to high intensity interval, 10 minutes cool down period. 4 educational sessions, risk. You try to what is the exact mechanism which occurs, what are the risk factors, and how to control these risk factors as an individuals, how to adapt any healthy habits or lifestyle modifications, how to manage stress and promote the self-managed care. So post-operative care, we start with phase 1. Phase 1 is usually, we do not mention the days, but it is what is called as a stabilization phase. Breathing exercises as we do to maintain the ventilation. So our main goal is to prevent the complication in the first phase, that is in the stabilization phase. So we concentrate on ventilation strategies, and we also see that there is a hygiene is also maintained, that is bronchial hygiene. That is done with postural awareness and with a careful monitoring of the vitals. So initially we try to maintain the ventilation with our breathing techniques, try to maintain the bronchial hygiene with postural awareness, and try to care with a vitals recorded, and try to mobilize the upper limb and start ambulating the patient inside the ward. Once he is out of the intensive care, we try to have a pre-discharge plan, or patients will be re-evaluated. So till now we have seen what is meant by exercise prescription, what is the basic principles of it, why how the behavioral strategy is very important before you prescribe an exercise. Try to interact with a patient before you prescribe exercise, and you need to rate or progress the exercise according to the requirement. So in phase 2, you start graded aerobic exercise. So it is started from week 1 to week 12, that is 3 months. Very gradually, 10% of progression is done every week with a warm up and cool down exercises. Along with the above exercise protocol, that is with aerobic or walking protocol, he has to continue the breathing exercises, upper limb and lower limb exercises, and do before and after the breathing to relax. When you are giving an exercise protocol, you should always record the heart rate and even teach the patient how to record in a heart rate or how to feel in a heart rate. Gradually, the intensity and duration of exercise needs to be increased, not all of a sudden. Even if a patient says, I'm very comfortable with exercise, now I can do 10 times or 15 times. No, you are not supposed to do all of a sudden 10 times or 15 times or 20 times. Very gradually only you need to respond, even though patient is very active and he's able to do the exercise. Deep breathing exercise has to be continued to maintain the ventilation. Warm up and cool down exercise, including ROM of major joints, has to be continued. And exercise should be withheld or terminated if you feel any discomfort of the problems. So you should be able to educate the patient when he's going to get discharged. What do you mean by discomfort? What do you mean by breathing difficulty? What is meant by chest pain? What do you mean by palpitation or oversetting and giddiness? Whatever the routine activity he's doing it, if he is doing the routine activities, but still he feels there is a fatigue, and the fatigue doesn't get subsided even with rest or after rest of 10 to 15 minutes also, he feels the same type of discomfort, then he has to be cautious. That has to be clearly explained to the patient before he discharged and make him understand what is meant by real discomfort and muscular or one which cause a temporary discomfort. He should be able to identify and he should be able to understand what is the difference between the chest pain and the normal musculoskeletal pains. Usually, if it is going to be a musculoskeletal injuries or pains, it gets subsided with the rest and the intensity doesn't remain the same after 10 to 15 minutes rest. That has to be explained. So you see in these photos is in a post mitral valve replacement cases where they have been given a chest physio for them and incentive spirometer is given for them with monitoring of the vitals. So these cases we have done a congenital heart diseases. We measured, we gave a supervised exercise protocol. We monitored physical parameters, physiological parameters, as well as the quality of life measures and nitric oxide measurements. We see what is the difference. Supervised exercise definitely has some change. That is what is this graph shows. BMI pre and post, which definitely improved with exercises, the physical changes which we have seen. And this is an ejection fraction which we have recorded in a pre-post intervention of an asymptomatic congenital heart disease group. This is nitric oxide which we have measured, which has been shown in pre and post. Definitely there is change. VO to peak which we have recorded, it is only the functional capacity which we could record among the patients with 6-minute walk test. And quality of life which we recorded with NS questionnaires, and definitely there was an improvement in quality of life in a post, pre and post, and especially in study group, that is in a supervised one. This is another study with mitral valve diseases which we have done, which is in a gender distribution where the BME changes which you can see between chest X-ray measurement, chest thoracic ratios, how it had a change. ECG changes which were shown. Ejection fractions between group 1 and group 2. You can see what is the gradient which was shown between group 1 and group 2. 6-minute walk test between group 1 and group 2, how the changes were recorded. This which was done by the PhD values which were recorded in acyanotic congenital heart diseases and valve replacement. The theme of the studies shows that when you do in a supervised exercise program for a post cardiac surgeries, definitely there is a change in physical, physiological and functional capacities. This is for a peripheral vascular disease, that is intermittent claudication. We get a lot of patients with intermittent claudication. So you get a functional walking, increase ADL and work of potential and quality of life. Neuromuscular, you improve the gait, and aerobic exercises, you improve the pain response, perform longer in time trials and grade achieved in the exercises. You start with 40% of VO to peak, intermittent walking to 3 on claudication scale 3 days per week, 20 to 40 minutes per session. And do it for 4 to 7, definitely you will have a increase in the exercise capacity. So intermittent claudication, you have an evidence-based physical training which improves the walking time and distance in people with leg pain from intermittent claudication were considered to be for exercise intervention. The possible mechanism with this, there is you can see there is a local production of the vascular endothelial growth factor, which induces the production of collaterals and increases the blood flow. Pulmonary diseases with cystic fibrosis or asthma, we see number of cases, but we don't, in practicality, we don't treat the lung conditions. Most of them go to the pulmonologist, take the bronchodilators or steroids or inhalers, and they continue. Once it gets reduced, they continue with their routine life. We see very few people undergoing exercises. In a corporate sector, this pulmonary rehabilitation is made mandatory to improve the condition of the lung conditions. Very few institutes are adapting this exercise or pulmonary rehabilitation. So how we can give this is neuromuscular exercises, strength exercises, and aerobic. You can give large muscle groups can be activated with a goal of increasing the VO2 peak, lactate threshold or ventilatory threshold, and develop more efficient breathing patterns and improve the ADL activities. Strength can be done with free weights or isokinetic. Increase the maximum number of repetitions or tasks. Flexibility you can do with stretching or Tai Chi, increase the ROM and neuro. So COPD, how it increases? It definitely leg muscle strength favoring a combination of resistance and endurance should be incorporated to have an improvement in COPD. Patients with COPD have TNF levels very high in blood and muscles. It has an impact on muscle tissue, and this affects a myocyte differentiation, induces CAXI and potential decrease in muscle strength. Danish study shows that physical training counteracts with COPD. Asthma, physical training has positive effect on psychosocial morbidity and quality of life. The possible mechanism doesn't improve lung function in patients with asthma, but it does increase cardiorespiratory condition in its effect on muscles and heart. A common hypothesis is physical training helps to reduce ventilation weight during exertion and reduces the risk of provoking an asthmatic attack. It also induces an anti-inflammatory effect in the lung. Cystic fibrosis, the goal is to mobilize the mucus in the lungs and stimulate increase in mucociliary transport, achieve a satisfactory level of fitness and strength to maintain normal capacity, normal mobility, especially for the chest to ensure muscular clearance, prevent osteoporosis and disease related to physical activity, and increase self-confidence. So quality of life, and inspiratory muscle training has been suggested as a mode of training to improve the lung function and quality of life. So what happens? It improves fitness and muscle strength and patient to be active, increases the pulmonary function by clearing the lung secretions. In summary, so out of it, we see that whatever it is lung condition or cardiac condition, try to understand the physiology, pathological mechanism and biomechanical aspect of it. Understand the patient perspective before you prescribe an exercise. Exercise always has to be prescribed from a slow level to a moderate to severe level. So the search of systemic reviews on exercise prescription in the area of cardiopulmonary, that is heart failure, coronary heart disease, asks for 20 to 60 minutes, at least 3 times a week for 3 to 26 weeks is advisable. A strong evidence says that the coronary COPD upper and lower exercises for 60 to 52 weeks duration improves their exercise capacity and experience and less shortness of breath. There is an insufficient evidence from a review of 7 trials that breathing retraining has some benefits, has a few benefits with asthma. Overall benefits of exercise should not be overwhelmed by the potential cardiac risk and damage, long-term overloading exercise training. Mechanics responsible for cardiac remodeling and dysfunction, which would help to provide feasible assessment and supervision of exercise training, is always advisable. The effects of modality, duration, intensity, frequency, and training on health promotion benefits and underlying mechanism of exercise will help exercise physiologists to determine optimal individualized training protocols. So there is a rising interest in endeavor to make personalized expression in recent years. That is, each and every individual with the different risk factors, what type of exercise should be given, still to be recorded in a scientific manner. So we yet to record whether if it is CABG patients with diabetes, what type of exercise to be given. If it is a CABG with hypertension, what type of exercise should be given. If a valve replacement patient is there, if he has got a risk factor of a clotting mechanism, what type of exercise should be given. If he is within a BME overweight, what type of exercise to be given. If it is in a congenital heart diseases, what all the type of exercise should be given according to the age factor and other comorbidity factors. If it is in a lung condition with other comorbidities, what type of exercise. This scientific evidence and research is still yet to be recorded in Indian scenario, and which we have to focus. So exercise prescription is in a specific plan for specific purpose. Keep the principles of exercise in your mind and collaborate with behavioral techniques, genetic characteristics and health status, and special consideration before you start rehab for the patient. So men and women makes a family. Mobility plus walking makes fitness. This we need to remember. Thank you for your patient listening. It is at most of them, it's time to go for bed, and sorry if it is in a long lecture. Thank you for, if any questions I would like to answer.
Thank you, ma'am. Thanks a lot for such a great deliberation and very good lecture with much evidence available. So we are really much honored and privileged to attend this great session today on the exercise prescription. So it was a great deliberation and the great learning ahead. We had enjoyed the session a lot. So with your permission, I would like to request if any of the participants having any query, they can ask. And although we are having a lot of feedbacks in the chat box, yeah, because the session was really outstanding and having a lot of good feedbacks in the chat box.
If any queries is there, you can give my mail ID also. If they want to have it, put the queries in mail, I can reply to them. Or in WhatsApp number, the same is my WhatsApp number, mobile number and WhatsApp. I can answer in WhatsApp also.
Okay, I think there is no query available here. It was very well elaborated and a great deliberated topic. There's one question, ma'am. Should I
Yeah.
narrate it for you?
Yeah.
What factors need to be considered while selecting the exercise frequency for patients with different conditions?
For
What factors need to be considered while selecting the exercise frequency for the patient with various other conditions?
Various other conditions, whatever the condition, either it is neurological or cardiac condition, or they want for neuro or ortho conditions. Whatever the condition, either it is cardiology or respiratory, neurology, or an ortho conditions or an oncology conditions, whatever the condition you are going to take up. Before you prescribe an exercise, I already insisted in my first slide itself, you should understand the past and present medical history, which is very important, and try to understand the comorbidities of the patient. Then go through his personal history, family history, socio-economical history. This has to be understood, and try to examine the patient, understand the general pathology of the condition and local mechanics of the part which you are going to treat. For example, if you are going to treat in a post-CABG, you should be able to see what is the type of surgery they have done, what is the duration of the surgery they have done, is there any events which has happened in the during surgery time, what is the post-surgery period, was it say uneventful or eventful, he had any other problems during or after the surgery, before you start the treatment and the phase 1 of cardiac rehabilitation itself. And similarly, if you are going to treat a patient with an post ICD placements, which is done for pneumothorax, or it is lobectomy or segmentectomy, you should know whether the condition is of tuberculosis or a patient is of an underlying disease of carcinoma, or a patient had a chest trauma and having an ICD, and that is the reason he is admitted, or with a comorbidities of smoker, he's a smoker or a known condition of lung disease, and everything before you start any treatment. If you are going to treat a patient with a stroke patient, you should be able to understand whether he is diabetic or a hypertension, regular medication or a irregular medication, and in what condition he is admitted. It is a first time stroke or a second time stroke or a recurrent stroke which he is admitted. If it is a first time stroke, what was his condition at the time of admission, whether he has improved or deteriorated. When you have seen the patient, you have to see the sequence of what was his prognosis. If you are going to see in a musculoskeletal condition, either it is in a knee joint pain or in a back pain, you should know what is the pain threshold levels which has increased or decreased with various medications or treatment, or with various activities, along with his all history levels, risk factors and history levels. And especially in ortho condition, you should also see the occupational history. If it is in a woman, you should see house woman, what is her activities. All these things has to be considered before you prescribe an exercise. Then you have to check the mechanics of the whatever the part which you're going to treat, and see the muscular properties also, whether the tone, how it is. If it is a spasm, how is the spasm? If it is spasticity, how is the spasticity? See the flexibility of the muscles, then joint structures, how is the range of the structures. Then you have to consider for the combined activities of whatever the upper limb or lower limb, how he is able to do. All these things has to be considered before you prescribe any exercise. Is it clear?
Yes, ma'am. Yes, ma'am. Thank you, and thanks a lot for again very great deliberation. There's one more question in the chat box. Is there any specific precaution and advice for the COVID-19 cases?
Yeah. COVID-19, as we have seen, lot of guidelines which have come. What I feel, what has been suggested by many of the specialities or the specialists, ventilation is one which has to be maintained. So ventilation can be maintained only with a breathing exercise. So this breathing exercise has to be done with full inspiration and expiration, and maintain bronchial hygiene with inhalation and clearance of secretion. And most of these things has to be adapted with COVID. And post COVID, most of the patients have any weakness developing in muscular strength. That has to be combined with nutrition as well as the gradual strengthening of the muscles. This muscle weakness is found mostly in aged persons rather than the middle-aged or in youngsters. So aged persons, we need to have a combined one. One is the nutritional part of it and the strengthening part, which is in a long run, and very slowly we need to progress the exercises. Is that clear, Himanshu?
Yes, ma'am. Yes, ma'am. There's one more query available in the chat box. I think I'm just looking for that. Yeah, there's one more question from Syed Masood, that systolic rate increases during the physical activity. Why not the diastolic rate?
Yeah, systolic and diastolic, you know that it is because of the dilatation and constriction. And we know that heart gets adapted to the exercises after certain time. Once it gets adapted, you don't find there is an increase in diastolic, only systolic gets increased. As we know that there is a constriction and restriction of the vascular structures which occurs, and this is a combination of sympathetic that is our parasympathetic and sympathetic nervous system, which aggravates in the initial phase and later gets stabilized when you get adapted to the certain type of exercises or whatever the stimulation which occurs in the body. And that is the reason you find that only the systolic gets increased and diastolic remains constant.
Thank you, ma'am. Thanks for great deliberation. And again, there is, I think, one more question. Let me finally. Yeah, we had a lot of participants from the overseas. I think there are a few participants who are joining us from the all corners of Asia as well as from Africa itself. So there is one question that if a patient is having brain stroke, and along with this, patient is also having asthma. So shall we start with the respiratory therapy simultaneously with the physiotherapy for the paralytic limbs?
Yeah, definitely. You can do both respiratory therapy as well as the physical therapy simultaneously need to be started, because the peripheral therapy, that is for stroke, you start doing it to maintain the joint ranges as well as the muscular properties, and respiratory exercise you start doing it to improve the lung conditions. You do it simultaneously.
Thank you, ma'am. Thanks a lot for such a great deliberation. and a great expertise on the topic exercise prescription to prevent and treat the cardiorespiratory illnesses. So we are really thankful to you for such a wonderful
Thank you,
knowledge.
Himanshu, for
Yes, ma'am.
coordinating, and thank you for the opportunity given. Again, thanks to our President and General Secretary, Treasurers, and all IAP members, and Dr. Harsh, who has coordinated this, and Uma Sen Gupta, who is there, and all my team members. Thank you.
So thanks a lot. Thanks to all the my respected teachers, Dr. Harsha, Dr. Charu ma'am, Dr. Ritu ma'am for always supporting and blessing us, and also thankful to all the senior academician researchers and the participant who joins us, who always supports us for our efforts to share the knowledge to each and everyone. So really thankful to you all for joining the session. And interestingly, we had the participant from around 6 countries today to join the session. And this is the aura of the talk of Madhavi ma'am only. And
Okay,
we are
thank you.
really
Thank you for all the participants who had shown the interest.
yes,
Only the participants are the inspirations for the speakers. Thank you.
yes. And at the last, there's information that tomorrow we had planned a session on the athlete's left ventricle, but due to some unavoidable circumstances, the lecture has been postponed and it would be rescheduled very soon. The information would be shared to each and everyone on the WhatsApp group. And if anybody wants the information, they can personally chat me on the WhatsApp. And so for tomorrow, we are having a very special resource person with us who is going to talk on a very special topic, a renowned personality, a renowned speaker, a great motivator, a great teacher, Dr. Harsar, is going to take a lecture with us tomorrow on the same time, 9 p.m., on the topic how to improve our practice smartly, not doing the hard work by doing the smart work. So we are really much thankful to her, sir, because suddenly there was some problem happens and we were not able to conduct the tomorrow's session with the as per pre-schedule. So this is just being scheduled right now. So tomorrow we'll meet again at 9 p.m. for a very good motivating lecture by the Harsh Rajdeep sir at 9 p.m. So stay tuned, stay safe, stay in touch with us. We'll meet again at 9 p.m. tomorrow. And heartfelt thanks to the Madhavi ma'am for such a great deliberation on a much needed topic. We are really blessed to attend the session with the Madhavi ma'am. Thanking you, ma'am. Thanks a lot.